Hello, I'm Mariam Zameer, Director for Immunization at Village Reach, with a background in health systems, born and raised in Pakistan, an immigrant to the US, and a mother. A few months after returning from parental leave, I had to travel to a global convening. My child was still nursing. While I was excited about the meeting, I quickly realized there was no organizational policy to support nursing mothers while traveling. I combed through our internal guidelines. There was nothing written, no policy, no guidance, no mention of what accommodations could be requested. So I had to figure it out myself. I drafted emails, asked colleagues, and made requests, one by one. Could the hotel provide a freezer? Could I take breaks during sessions? Was there a dedicated pumping space? Could I bring a caregiver and infant? Could I carry milk through security? The burden of planning and navigating while nursing when traveling falls almost entirely on individual women. And the cost isn't just logistical, it affects careers, confidence, and participation. Many women feel that they have to choose between work travel and their baby, and that declining to travel impacted their leadership opportunities and visibility. For most women who do travel while nursing, the experience is logistically exhausting, emotionally taxing, and largely unsupported, as you can see from the quotes on the screen. When women did choose to travel while nursing, their experiences followed a very consistent pattern. First, the logistics of the journey itself were extremely difficult. There was little to no logistical and financial support to bring the child and caregiver along. For those who did travel with their baby and caregiver, they had to cover the costs themselves. Many women said that they couldn't pump on planes or in airports because there was simply no space or privacy, especially in economy class. Long flights or layovers often meant no cold storage at all, forcing mothers to choose between the stress of transporting milk unsafely or dumping it entirely. Then, even at the destination, support was inconsistent. Many described challenges securing a fridge or freezer at hotels despite advance requests. At conferences or global health meetings, there were often no dedicated pumping space and no flexibility in schedules to allow for breaks. And finally, there was what I call the motherhood visibility penalty. Women shared that they turned down travel because of these barriers and felt that this affected their leadership opportunities and visibility. Several described pumping and dumping as demoralizing, especially knowing that saving the milk would have required a few $100s in basic logistical support. When asked about solutions, the message was clear. Women wanted practical institutional support, coverage for milk storage or shipping, support to travel with a baby or caregiver when needed, and flight upgrades that allow for privacy and safety for pumping. They also called for cultural and policy shift where hotels, conferences, meeting venues are required to provide clean pumping spaces and guaranteed refrigeration. And most importantly, they want to move away from having to beg for accommodations towards clear, written travel policies that are proactively shared with every nursing mother so support is assumed, not negotiated. My leadership project started with a very personal experience, but I soon realized it is a structural issue in global health leadership. Organizations often congratulate themselves because they're able to provide time off after a child is born or have a lactation room in office. But is that enough? Even without explicit penalties, women describe self-censoring, opting out of opportunities because the logistical and emotional burden of nursing while traveling was too high without institutional support. Many nursing women traveled specifically to avoid missing leadership opportunities despite the toll. They pushed through exhaustion, discomfort, and stress to maintain leadership presence, essentially absorbing the cost themselves to stay competitive. Their continued participation comes at a personal, emotional, and physical cost that is invisible to institutions but unsustainable over time. The impact I'm working towards is simple but powerful, ensuring that leadership in global health is at least gender inclusive and not quietly excluding mothers. I plan to continue building the policy and advocacy toolkit to use as a practical entry point for policy change. On a personal level, this journey has reinforced my commitment to lead visibly, advocate clearly, and create space for others to do the same. My goal is not just to change policies, but to help reshape what leadership looks like in global health so that future women leaders don't have to choose between being present for their families and fully showing up as leaders. If we say we value women's leadership in global health, but haven't designed our systems to include them, what message are we actually sending about who belongs at the table? Thank you.